So why is it that whether Miss B resides in a U.S. nursing home or a nursing home in Ontario, she's likely to transfer down the street to the hospital? Well, I think the answer involves both payment and delivery level failures. Let me talk about both of those. In the U.S., in terms of payment for a long-stay nursing home resident, one with long-term care needs, Medicaid's typically going to pay for that care. So think about the case of Ms. B. Medicaid is paying for her nursing home services, yet the Medicare program is paying for her hospital services. So when the Medicaid program invests in preventing hospitalizations, those savings don't necessarily go to Medicaid, they go to the Medicare program. And so this disconnect has led to a lack of coordination in terms of Medicaid's investment and the return on that investment. This disconnect then translates down to the delivery level. Medicaid's not going to pay nursing homes to prevent hospitalizations. And thus, nursing homes and other related providers don't invest in the infrastructure and the expertise to safely treat residents in the nursing home setting. So as I said in the introduction, I think you have to address both of these failures. And let me put this together in a 2x2 matrix. You can see here that we have both delivery and payment. So payment here on the horizontal axis, we can think about, in the lower left quadrant there, the status quo in the U.S., and that both, payment is typically done on a fee-for-service basis. So nursing homes are paid separately from hospitals and physicians and other providers in our system. And we can think about as we move out and begin to pay providers in a global, more accountable way, where nursing homes are at risk, so to speak, for hospitalizations and have the opportunity to share in some of the savings when they prevent those hospitalizations. Along the vertical axis here, you can see that currently the status quo in the U.S., the traditional model, is very fragmented. Nursing homes don't work with hospitals, don't work with physicians, and so on. And as we think about all of those providers working together, we get a more coordinated model of care. Obviously, we want to get up to that upper right quadrant where both payment is global in nature and providers are all accountable to the system and to one another. And we want to get at the delivery level, providers all working together in a coordinated fashion that puts the patient or the nursing home resident first and not simply operating based on financial incentives. Let's think about first, before moving up to that upper right quadrant, which is obviously the ideal, let's think about simply fixing the delivery, better coordinating care on the ground in terms of delivery innovations, but not tying that innovation to any sort of payment reform. And I want to give two examples from my own research. The first is from telemedicine, and that seems appropriate today given that I'm joining you remotely. And then second, I'd like to talk about another example from my research with other colleagues in terms of toolkits in the nursing home setting. So let's start with the example of telemedicine. So if a medical issue arises in the typical U.S. nursing home, let's imagine it in an evening or a weekend, there's no physician on site at that nursing home. Typically, there's a covering group of physicians who likely don't know the patient. So think about the case of Miss B with her cough and her fever. That happens on a Thursday night. There's going to be a physician that gets a telephone call typically, and that physician can either come over to the facility and see Miss B, or that physician can recommend that Miss B be transferred to the hospital. Given the incentives in our system and the fact that this physician, does not have a close relationship typically with Miss B, all too often the on-call physician simply sends patients like Miss B down the street to the emergency room. And I gather from your data that Paula shared for me from Ontario, this is happening a lot in your system as well. Telemedicine provides the opportunity for two-way video conferencing and a real-time physician consultation. So when Ms. B has that fever and cough, they would bring a two-way video cart, and all of a sudden Miss B and her family and her nurse are all looking eye to eye with a physician. And what we argue and hypothesize in this study is that this sort of direct physician contact will prevent some unnecessary hospital transfers. And that's exactly what we found when we conducted a pre-post randomized study here in a Massachusetts nursing home chain. And this work was published earlier this month in the journal Health Affairs, if you want to learn more about the study. But basically we had 11 nursing homes in this Massachusetts nursing home chain, and we randomized 6 of the facilities to get the intervention, and 5 of the facilities maintained the usual group coverage model I just described. In those 6 facilities, as you can see in the figure on the right, they experienced a 10% decline in hospital transfers with the telemedicine, relative to a 5% decline in those controlled facilities. So a much larger decline that actually translated into about $100,000 in savings to the Medicare program from prevented hospital transfers. Now, the telemedicine service costs $30,000 per facility per year. So we saved $100,000 and only cost us $30,000 per facility per year. You don't need a PhD in finance or economics to realize that there's a return on investment. So the question is, why doesn't every nursing home in the United States have this kind of off-hour telemedicine coverage? I want you to hold that thought, and let's talk about Toolkits. So a second example of delivery level innovation are Toolkits. I know that Joe Oslander, my colleague, presented last year as part of this exact meeting. So hopefully you're familiar with Interact. And remember, it's basically a quality improvement tool that's implemented at the level of the direct care worker in nursing homes as a mechanism to prevent unnecessary hospitalizations. It's a pretty simple toolkit, but it takes a lot of effort on the part of the nursing home and their staff to implement. But once implemented, it helps the direct care workers on the ground identify a nursing home resident's change of status. Think about Miss B again and that fever and her cough. It'll guide that direct care worker through a comprehensive assessment once that change has been identified. It allows the staff member to document the change, then ultimately to communicate with nurses and physicians about this change in status. In all of these different steps, we wanted to see whether they actually prevented unnecessary hospitalizations. So we were able to do that in a pre-post evaluation of 25 facilities in Florida, Massachusetts, and New York. And we found 11 facilities that we just matched. So this wasn't a randomized trial. This was simply a kind of a match control study. And we found in a paper we published in 2011 in the Journal of the American Geriatric Society that those facilities with the Interact model in place experienced a huge decline in hospitalizations, nearly 19%, relative to about a 4% decline in those control facilities. So when we differenced out the savings here, each nursing home that participated, that used the Interact model, saved the Medicare program about $125,000 annually. The cost of the facility in terms of staff training and paperwork and time is trivial relative, several thousand per nursing home per year. So once again, why doesn't every nursing home in the U.S. have the Interact model in place? Well, the answer there really involves this disconnect between who pays for the intervention and who gets the return on investment. Once again, the nursing homes in these two studies, Telemedicine and Interact, had to pay to implement the intervention, whereas the Medicare program enjoyed all the savings. And as long as this is the case, any kind of investment in these sort of delivery level innovations is going to be quite limited and quite unsustainable. And let me give you 2 examples from each of those studies. I'll start with the telemedicine. So ideally, when the nursing home chain began working with us, their thought was that they would do the randomization and basically bring those 6 treatment facilities online with telemedicine as part of our study. Those 5 control facilities were supposed to implement telemedicine at the end of our study period. However, they never implemented telemedicine, even though we had very promising results from our study, because right at that time, the Medicare program had a huge payment cut in terms of how much they were paying skilled nursing facilities for short-stay rehabilitative care. The facility could no longer cross-subsidize telemedicine for all of their patients. They just didn't have as many resources as they did at the beginning of the study. And so it was a really strange result to have these very promising findings from our study juxtaposed against these decisions on the part of the provider. But the answer here is very simple, and the reason why we have this disconnect. Nursing homes are paying, Medicare's enjoying the savings. Obviously, we need to bridge that disconnect if we want to make these programs sustainable. Same issue with Interact. We work with a number of different facilities to implement this model and to help them with the model and study how the model prevents hospitalizations. However, once our study team pulls out, as you can imagine, huge sustainability issues, because many nursing homes, at least historically in the US, have not been at risk for hospitalizations. And so there's only very limited incentive to actually sustain the model.